Okay. I'll let you know when it's up.
Okay.
Okay.
Thank you. Good afternoon, committee members, guest speakers, and those following us on YouTube. We greatly appreciate you being able to participate and observe on very short notice. So thank you for all of you, particularly the committee members and our guest speakers today. The purpose of the briefing this afternoon is about protecting our children, protecting school staff, and indirectly protecting the community at large. Because obviously, if someone contracts COVID in school, they can spread it to their own family, their own community. So while we're focused on schools and the school community, it has implications for the community at large. And let me start by, first of all, thanking the State Board of Education and the new State Superintendent, Chaudhary, for taking the action they did earlier, late last week. I think many of us appreciated the majority of the counties have already taken that stance. So we're very appreciative that they also saw the need to meet an emergency session and take the vote to make masking a requirement across the state. It's my understanding ALR will be meeting soon for a hearing and hopefully a quick vote as well. But having said that, today's meeting and briefing is more than simply the mask mandate, which is very, very important, I think, if you all understand. It's to talk about other steps to protect our children, the school community, and again, the community at large. So we're going to have the speakers today talk beyond not only about masks in school and other protective measures that can be taken to preserve the health of our school community and the community at large, but we want them to open it up to other questions, other steps that we should consider. Among those, obviously, are required vaccination for school staff, which some jurisdictions have implemented. Some have called for required vaccination or regular testing. There are some places around the country that have actually called for required or mandated a vaccination for eligible children, 12 and over. So we want to leave this open to a broader conversation. Schools began for a number of jurisdictions today. A number started last week, and at least one starts after Labor Day. So that's our purpose for today. And let me very quickly explain the format. We have 4 speakers, and as I've shared with the committee, we want to keep it very tight to about 90 minutes. So our speakers can go on to other professional and very important work they have, as well as the committee members. We have 4 speakers. I've asked each of them to take 5 to no more than 7 minutes to present some of the important information and facts and challenges. And then we'll have 10 or 15 minutes after each speaker for the committee to ask questions. And then we'll move on to the second, third, and final speaker. So that's the plan for today. I don't want to use too heavy a hand, but let's try to be aware of the time and our time limit. So if we can keep our questions fairly succinct and tight, that will allow for even more questions to be asked. So with that being said, let's go to our first speaker, and that's Dr. Karen Kotloff. She works at the University of Maryland School of Medicine. She's head of the Division of Infectious Disease. She's Associate Director of Clinical Studies for Vaccine Development, and she's also board certified in pediatrics. We've asked her to talk about the impact on children and the need for mitigation efforts. So with that, Dr. Kotloff, if you are with us.
She just joined. It might take her a second, Senator Pinsky.
Okay, then we're going to show a little patience. There's some logic and order to our guest speakers. So as soon as she's on via phone. Okay, Dr. Kotloff, I've introduced you, and we welcome you and appreciate you taking time out to join us. Okay. I see her iPhone is on. but you're not connecting, Dr. Kotloff. Okay. Can we text her and see if there's a problem? If we have to, we can go to.
Let me see if I can get her offline.
Then we can go to Dr. Salmon.
Okay.
Again, this is all done on short notice, and people are between visits and meetings and offices and hospitals.
I'm sorry, did you want me to go first?
Dr. Salmon, wait, we're going to give it 1 minute, and if we can't connect because she's trying to connect via phone and not Zoom, we'll go to you. So I'd like to start with her if possible. If not, we will proceed with you.
That sounds great.
Okay, let's do that then. We're going to shift, and Dr. Salmon, his primary research and practice is optimizing the prevention of childhood infectious diseases, which is obviously the area we're looking at. His focus has been on individual and community risk of vaccine refusal, and he's also looked at exemptions for school immunization requirements in state laws in various places across the country. So with that, Dr. Salmon, welcome, and you're on.
Thank you. I think Ross has some slides that I've put together. Is he able to share them? I don't think I have.
Yeah.
There you go.
Okay.
And maybe we could start at the top. Beautiful. Oh, go back a few slides. So, I'm just want to start by putting this next slide. That's me. That's my talk. That's who I work for and what I do. I direct an institute for vaccine safety. And, just to put this in the context, prior to COVID, WHO determined that vaccine refusal was a top 10 global health threat. So just keep in mind as we think about COVID and controversies around vaccines, they're certainly not new. It's been a growing problem. Next slide. If you look at measles in this country over the last decade, we see more cases in 2019 than we've seen since we eliminated the disease. These are largely outbreaks among communities and persons whom refused vaccines, typically being imported from Europe or other countries. Next slide. Just looking at what is compulsory vaccination broadly, it's when vaccines are required of the population broadly or a segment of the population in either to live in that jurisdiction or to receive an entitlement. So they come in all sorts of flavors and styles. Next slide. But most, if you look at the evolution in the US, the first compulsory laws were for smallpox vaccine against the general population. Here we saw US Supreme Court ruling Massachusetts versus Jacobson. And this case, which the Supreme Court ruled in favor of Massachusetts, upheld the state's police power to compel vaccination, and is really the foundation for public health law in this country. Around this time or shortly after, there was a push towards universal education, and schools became universal, became mandatory, and then requiring vaccines for school entry became linked. And the US Supreme Court also ruled in favor of this requirement for vaccines for school entry in Zuck versus King. And that's really going to be my focus here, because I think that's the interest of this group. Moving on to the next slide. So we saw a growth of school laws and school entry laws in the latter half of the 20th century. In 1963, there were 20 states that had laws. In 1970, there were 29 states. And around this time, we saw a lot of measles. And measles was hitting school-age children disproportionately, and often schools were a site of disease transmission, and it was very disruptive for schools as well. Moving on to the next slide. There were a couple studies done at this time, 1973, 1974, where they compared the rates of measles in states with laws compared to states that didn't have laws. And we saw that the existence of laws was associated with much lower rates of measles. But, as often is the case with laws, simply having a law isn't enough. Moving on to the next slide, a study done a few years later looked at states that strictly enforced the laws versus the rest of the country and showed again that, existence of the law was great, but you really had to enforce it if you wanted to have an impact. And it was through these studies at these time where we really saw every state start to require vaccines for school entry. Next slide. So the initial intent of laws, school entry laws, mandatory vaccination, was to prevent outbreaks of disease, smallpox and then measles. But, they have other benefits as well. They provide a safety net, ensuring that nearly every child is vaccinated by school entry, which has some real advantages in terms of equity and catching lower income minority children. It shows a public commitment to immunization. It makes it a social norm, and it can be helpful in introducing new vaccines such as varicella and other vaccines as they're licensed. Next slide. So how do these work? They're all state laws. There's no federal laws that are in effect. This, as I mentioned, is a part of the state's police power. There's a lot of variability in terms of what antigens or vaccines are required, how new vaccines are added, what populations. Typically it's school entry. It can also be daycare, middle school, universities, and then even who provides the documentation. In most states, this comes from a primary care provider, the child's doctor. Some states allow parents to document it. Next slide. So all states offer exemptions, at least medical exemptions. This is a map from our website, and you can actually click on the particular state and see the exemption law. Many states offer non-medical exemptions, sometimes called religious or philosophical or personal belief. And again, there's tremendous variability between states. Next slide. And what we found, and we've been doing research in this area for a couple of decades, is that there's a lot of variability in how states implement and enforce the exemption laws. That often there's some states that have very easy processes, like Maryland, and some of those states have higher rates of exemptions. There's a clear association. Often there's little contact between the parents and the health personnel. They're really just enforcing the law. The majority of states, and these data are a bit old, never actually deny an exemption request. So whether it's called religious like Maryland or philosophical in many states, it's de facto by anybody who wants one. And ultimately, the states rely on schools to implement and enforce the laws. Next slide. So we've done a bunch of studies looking at the individual and community risks of refusal, right? So if I don't vaccinate my child is at greater risk of disease, and then my child may put your child at risk. Maybe your child is too young to be vaccinated. Maybe your child can't be vaccinated for medical reasons, or maybe your child was vaccinated, but no vaccine is 100% effective. So they may still be susceptible. And we've looked at this for measles, pertussis, and varicella or chickenpox. The next slide shows some of the measles data. And we found that children that had exemptions were 22 to 35 times more likely to get measles and about 6 times more likely to get pertussis compared to children who were vaccinated to get into school. The next slide. We've also looked at the impact these children have on other children. These are data from Colorado, where we saw that counties that had outbreaks of pertussis had much higher exemption rates than counties without outbreaks. Next slide. We also found that the type of exemption, religious or personal belief, and importantly, how easy or hard it was to get the exemption, was associated with pertussis incidence. So we found between states and within states that the difficulty of getting an exemption really makes a difference. Next slide. Another factor to consider is the clustering of vaccine refusal. And this is true very much so for COVID today. This is an older map from Washington State where the overall refusal rate was about 5%, but you see counties with rates as high as about 20% and 25%. And within those counties, schools with even higher rates. So, vaccine refusal is very much like politics where it's a local issue. And looking at national coverage or even state coverage will often not let you see these susceptible, smaller community level refusal rates. Next slide. This was a study that we did, you can advance this, looking at the rates of refusal, and this is in Michigan. And we found if you lived in a refusal cluster, you were 3 times likely to also be in a pertussis cluster. So again, getting at this community risk. Next slide. So what about school mandates for COVID vaccination?
Dr. Salmon, you're going to have to wrap it up. We're on a tough schedule today.
Yeah, okay. I just have a couple more slides. Next slide. I really wanted to show you, there's an association of immunization managers. So these are the people that run state immunization programs. And they came up with a list of criteria that one would want to use when mandating a vaccine and emphasize that you want to use them sparingly, approach mandates cautiously, and wait until you have an implementation period. Next slide. And I think the places where we haven't yet gotten there is widespread public and physician support, adequate safety data for a mandate, and lastly, the risk that if it's prematurely implemented, you can have backlash. And then just my last slide, this is a caricature of an HPV mandate that was pushed in Texas prematurely. And this is what you want to avoid, right? The perception that mandates are being used to sell a product or to push a product. And I just give this last slide as a warning that we need to be thoughtful before we consider mandates in the COVID world.
Thank you, and I apologize for hustling you through, Dr. Salmon. Let's open it up for questions from committee members for Dr. Salmon. Senator Carrozza. Please unmute her, please.
Thank you. Could you go back to that one slide that I know we had to go over really fast on some of the issues to take into account when you're considering mandates?
Yeah, and I apologize. I thought that I had 11 minutes and not 5. So
that's yeah. And I know that seemed really. You circled some of these as.
It's where I think we're not quite there yet.
For what reason?
Well, I think we're not quite there yet. I think that these are the criteria that are nicely laid out, and the ones that aren't circled, we've probably accomplished that for COVID, right? Like there's enough vaccine for everybody free of charge. And that's essential. You can't require something people can't afford. But the ones that I circled were the ones where I think we're just not quite there yet.
Okay, Senator Ellis, please. We can come back to you later if you have a follow-up, Senator Carrozza. Senator Ellis.
Yeah, thank you, Mr. Chairman, colleagues, Dr. Salmon. Thank you for your presentation. This morning I went to, this is our first day of school in Charles County also, and I went to Billingsley Elementary School all morning, got there early first thing, and it was amazing how every single staff member and kindergartner on up were masked. Everyone had their mask on happily for the first day of school. And so seemed like the reaction to the mask mandate and encouragement is unanimous. It's just amazing. How do you feel the reaction if we have to mandate vaccination for students and staff for that matter? Do you think it will probably have an equal positive reaction?
Well, so, I spent a lot of time thinking about this and in the context of requiring vaccination. And one typically thinks about what is the burden of disease, how effective is the intervention, are there other interventions that might be suitable, and how intrusive is the infringement on autonomy. And in the case of masks, it seems really simple. I mean, it's one of a few things you can do. It's not a huge infringement. It works pretty well. I think with vaccines, the equation is a little bit more complicated. I never would have predicted how controversial masks have become. I think the argument for teachers is easier and more compelling than it is for children, both because it's a workplace issue and therefore a requirement for employment versus a child who is a vulnerable population. We also have less data on children. So I think that it's harder for vaccines than for masks. I'm pleased to hear masks weren't a problem. I hope the same is true in my children's school. And, I think that I would probably start with teachers before children.
Okay, thank you.
Before I go to Senator Lamb, just a very quick follow-up, Dr. Salmon. If CDC and now FDA has said it's safe and appropriate for young people 12 and up to get the vaccine, is it still complicated for young people 12 and up if it's proven by science that it's appropriate and holds off the infection? Would that also hold for schools?
Yeah, but yes. And we've seen a full approval now for one vaccine, though not as young at ages as we see. But I think the burden for safety is higher to make it mandatory than it is to make it authorized or licensed. So, they're all important. The approval is meaningful. But science is how well do you know something? Or in the case of vaccines, how small of a risk can you exclude? And I would argue, and I think many would agree, that to make it mandatory, you need more confidence in the safety than you would simply to make it available.
Thank you. Senator Lamb, welcome. I know you're in a challenging situation. We wish the best for your wife. Dr. Lamb.
Sure, thank you. So my question was to follow up on Senator Pinsky's question, which was, from your perspective, do you think that it would be then appropriate once FDA either authorizes or approves a vaccine for children to be able to mandate it? I know you cited a few things in that last slide, and I don't know where either FDA approval or authorization fell under that, and there's a distinction obviously between approval and authorization, but what are your thoughts on that?
So my own belief is we need approval and not just authorization in order to mandate it. And we don't have that yet, at least for children or younger children. So I think that's an important piece. I don't think it's necessary, but not sufficient would be my response.
And then for approval, obviously that's going to take longer than just emergency use authorization. In the meantime, there are risks to children contracting COVID, obviously, potentially in schools from other children, also from teachers as well. How do you balance those risks in saying that it should not be provided until it is, or required until it's fully approved, even though it may be authorized for certain students? Like right now, it's authorized for certain teenagers in that proper age range.
Yeah, so your question is a great question. And my answer isn't just about risks and benefits, but it's pragmatic. And if you try to mandate a vaccine before you have widespread support, you really risk public backlash. And HPV is a great lesson in that. The premature effort really undermined the immunization program for decades. So we could be in a place where the benefits outweigh the risks. So there would be an ethical, even perhaps a legal argument for mandating it. But if pragmatically it creates great backlash, you may not actually accomplish much other than undermine confidence in the program.
Would you have any objections to mandating it for teachers and staff?
I think the bar is different, as I mentioned. I mean, firstly, that's a workplace mandate, which is different. And teachers get to choose whether or not they want to be teachers and where they work. And it's an occupational hazard. So I think it's a lower bar. they're also not children. They're not vulnerable from that perspective. So I'm more comfortable with mandating for teachers, which we do have a vaccine that has a full biological license application approval than I would be for children.
And I
Okay,
think
thank you.
that serves as a good segue. We have 3 more speakers. We're going to go to the practitioner, the implementer, Dr. Golson, who's dealing with these very questions with her staff and with students. Then we'll come back to Dr. Kotloff. I hope you can bear with us, Doctor, and then to Dr. Sell. So,
Mr. Chairman?
next, yes.
I think maybe you didn't see my hand up. Do you want to move on, or should we? I did have a question for Dr. Salmon.
If we can move on, Madam Vice Chairman, I'd like to do that. I did not see your hand. I apologize.
Okay.
And Dr. Salmon, feel free to go on to work, or if you'd like to stay, we appreciate you giving us this time.
Thanks. I'm going to drop off if you don't mind, but if
Okay.
somebody wants to email me a question, I'm happy to respond by email or even have a private call.
Great. Thank you.
Thank you.
Next person is Dr. Monica Golson, who's the Chief Executive Officer of Prince George's County Public Schools. Also, in some cases, would be called the superintendent. She has risen up through the ranks, 29-year career in the county schools, has done a fantastic job. Obviously, it's my home county, and she is someone who does a wonderful work with the county, instilling confidence, and she's had to deal with these concrete problems over the last 15 months in general, but more specifically, the last 2 or 3 months of making these tough calls on what to require and what not to require. So with that, Dr. Golson, welcome. Talk about the vaccine policy, how you've come to your decision making, and what's going to guide your decision going forward. So
Yeah, thank you so much. And I did send a PowerPoint presentation, so I'll go quickly through that. And I appreciate being on because I was able to hear the conversation around student vaccinations, which we are constantly talking about every day here. So it was good to hear another perspective. I'm going to try to go through this quickly because I feel like the questions are probably more valuable than what I'm probably going to share. We started and gratefully were part of phase 1B around vaccinations when the release of the vaccination was done in December of 2020. For us, though, I knew that once the governor announced that we had to open schools on March 1, because we were the hardest hit county in the state of Maryland, getting the vaccination was going to be key in order for me to make sure that the staff would get back in and parents felt comfortable for sending students back to school. So we implemented a survey in January to find out how many people said that they would get the vaccination at that time. And that also helped to serve for us. Out of the 12,479 people responded, I have 19,000 employees. So that just lets you know I had around 6,000 that didn't respond. It allowed me to kind of figure out what I needed to do some pushing out of facts around the vaccine and who I needed to try to convince. Next slide. So around January, after we did the survey, I realized then that I needed to be the facilitator of trying to get people to get out to get the vaccination. So I contacted Kaiser Permanente, which is one of our healthcare providers, and the local health department, and asked, could they help me to facilitate the distribution of that vaccination, which meant that for us, what I did was I provided a link through the PGCPS email system for every employee to sign up. We had a certain number of slots per day. They were done on the weekend at our sports and learning complex, and our nurses were the ones who did those vaccinations on the weekend to try to alleviate any concern or fear that people had. Kaiser Permanente had to do theirs at their location, at their site location. That was helpful for our building services staff because they could pick a variety set of hours Monday through Friday that didn't interrupt the delivery of instruction. We used our sports and learning complex on Saturdays and Sundays. And then the other incentive that I used to get people to go out was then I provided them vaccination leave. So if they provided proof that they went to get a vaccination, then they were allowed to take leave. I speak constantly with them. We have a panel of 5 medical advisors. One of the things they said is that most cases many people didn't have a consequence after the first vaccination, but they did after the second. So it was important that we gave the leave for both first and second dose. And luckily the first dose wasn't that bad. So then people would go back for the second dose. And then we gave the leave for that. That's how we were able to track at that time how many people got the vaccination based on our COVID leave, our vaccination leave. And we coded it in our system because at that time we couldn't ask who was going to get the vaccination and who was not. Next slide. Of course, I pulled back in May the data to see how many of our employees had actually utilized COVID vaccination leave. We had about 10,000 employees. And then we realized that as we started to analyze that data, that there were some people missing from that data. And I'm going to give you an example would be me. I got the vaccination, but I didn't need to use COVID leave. I didn't need to use the vaccination leave because I didn't get sick after the first or second one. I happened to take it on the weekend. I did it at a time because I figured I can't afford to take off a day from work. So I made sure I got that vaccination on a Saturday. I rested on Sunday and was back at work on Monday. So knowing that, we realized, okay, we got an outlier out here of people who we don't have in our database. And the COVID-19 Delta variant was starting to ramp up, and having the vaccination for staff became really critical. For us being, the next slide, us being the highest county with COVID-19 results, we needed to increase our vaccination rates. And so you see here where we have vaccination data outlined. We try to post this information regularly so our staff sees it. I meet with our health department every other day to get the number of students, of percentages of students who are vaccinated between the ages of 12 and 19. So while this information was helpful for me, I still felt like we weren't in the 90% where I felt like we needed to be, for me to be able to sleep at night, knowing that staff would be vaccinated and around K-6 students who do not have the vaccination, who have not access to the vaccination. Next slide. So after consulting with our medical practitioners and our team, as well as our nurse supervisor, I made an announcement on August, about 2 weeks ago now, that we will be requiring vaccination for all of our staff. They had to provide proof by this past Friday. And now we're compiling that information in a database. And then for those employees that do not get the vaccination, then they have to do weekly testing beginning Monday, September 13th. We go back to school next Wednesday, which September 13th might seem far away, but next Wednesday is the 8th. It's a Wednesday, which is why we wanted to start on a Monday. Every Monday, those employees that are not vaccinated will have to take that COVID-19 rapid test and the PCR test. The rapid allows them to go from that health room to the classroom. PCR lets us know if we had any false negatives, positives, and results from that rapid test. We also do COVID testing for students and staff who have symptoms. So anytime that a teacher senses that a child has some COVID-like symptoms, they'll contact the nurse, they'll come and get them, and then they take them to what we call our care room, which is not where every other child goes for health issues. They literally go to be tested and contact parents. We do have an exemption, accommodation for medical and religious vaccination exemptions. The previous presentation talked about if you don't really check it, then the people kind of slip through. Ours are actually going to our Office of General Counsel to fully review. Because what I don't want people to do is to fall on and say for religious reasons and not really document that that truly is the case. I do know from many, I check my emails, I have assistants, but I check mine most of the time. And some of the people who were holding out, now that we have required, have said, okay, now you forced me to go and get the vaccination. And in my mind, what I considered is I'm now forcing them to take ownership of their health and remain alive. That's the way I see it. Next slide. So, of course, as I shared before, why are we doing it? Having a mask is key. We never let up on wearing masks in our facilities. Of course, at the time, our county, once school concluded, we could take it off outside, but now we're back to outside and inside. We continue to pay attention to the number of breakthrough cases, but they pale in comparison to the number of situations that we have where people who are not vaccinated. And to reassure our community that it was safe for them to return to school, I felt I needed to make sure I protected our staff and our students and the families that our staff goes back home to. because that's key as well. And then, of course, as I stated before, the weekly test for unvaccinated is key, along with the vaccination encouragement. Last slide, next. So we're working with vendors to provide tests for asymptomatic individuals, so much as at our bus lots. We have 13 bus lots. I'll have someone to do testing at the 13 bus lots. Testing will be done in schools for the school-based staff, and then for central office staff, they have to go to hub locations. And we're now working that out with vendors now and continuing to push out any media that we can around vaccinations. Now that we're kind of really moving past staff, we're now focused on athletes. That's why having this conversation today was key. I had some students do videos, and we were pushing them out on Twitter this week around athletes being vaccinated. And we have mobile units that have been going to all of our high schools and middle schools throughout the summer. We're going to start it again. Right now, the date that was just given to me right before we got on was September 20th. I said, that's too late. So I'm asking them to move that up to start the rotation again. This will be our third rotation of mobile units going to middle and high school sites to do vaccinations. That concludes my presentation, and I'm ready for questions. Sorry to go so fast.
No. We appreciate Dr. Golson. You have to make these tough decisions every day. Questions? You can either raise your hand, start with Vice Chair Kenyon. I apologize for the last speaker.
No worries, Mr. Chairman. Thank you very much. Dr. Golson, I don't know if this question is as appropriate for you as for Dr. Salmon, but I'm going to try it. This committee and the General Assembly passed emergency telehealth legislation each of the last 2 sessions. And this year it was to make sure that our students got access to primary care, behavioral care, and dental care in our school-based health centers. When and if it becomes appropriate, has Prince George's County Public Schools had any conversations about whether it would be appropriate to give vaccines in those school-based health centers? Would love to hear your thoughts about it. And thank you for being with us.
Yes, thank you. So yes, we have had a discussion around it, and there's so much red tape that, to be honest, that is why I moved quickly to the mobile units, because I could get those on the parking lot. We have 4 wellness centers in 4 of our high schools, and we have 6 new schools that are being built that we're putting wellness centers in. So we have to tackle the red tape, the legal piece of it, of doing the vaccinations on our site. We're working through that. I can definitely follow back up with you on when I think we'll be close to solidifying that, and then whatever issues we ran into, so you would know. But because, it's so fluid, I had to come up with something quickly, and that was the mobile units first.
Well, if I could just ask a very quick follow-up question, is the red tape, does that come from the Maryland State Department of Education or somewhere else that we might be able to help alleviate in any way?
Yep, it's around the legal ramifications of who offers the vaccination on our site, making sure they have the liability coverage.
Yes.
Yep, it's really around that. Yep.
Makes sense. Thank you for your leadership.
Sure, thank you. We can't hear you, Senator Pinsky. You're unmuted.
Thank you. I have to be reminded. I don't see any hands. Let me ask a quick one.
I think Senator Washington.
Senator Washington.
Hello, good to see all of you. Thank you, Doctor, so much. And thank you so much for being on the front line of things and making these quick decisions. I have 2 questions, but first I would like your feedback or reactions to Dr. Salmon in terms of balancing. Essentially what he's saying is a political question of keeping our children safe versus a sort of a public health reality. So it sounds like you've been balancing that. Could you sort of talk about that a little bit? Do you relate to that? Is what he's saying in terms of being. Yeah,
I have to be honest. If I focused on the political piece of it, I'd never be able to make a decision.
Thank you.
And so I have to focus on the health side of it. I'm sorry.
Yes.
I have to go to bed at night because I represent 134,000 kids and 19,000 employees. And sometimes I do have to make the difficult decisions, but it's for every life. And so I appreciate the conversation earlier from Dr. Salmon. I was getting encouraged because I followed up on Maryland and the code. And I know that the health department, Maryland Health Department, controls adopting the rules and regulations that govern student vaccinations. That is why my hands are tied. Because if that article did not exist, section 7-403, I would have required athletes by now.
Would you say that again? So thank you. I'm happy that that's where I wanted to get the reality, sort of the academic, which is great. We appreciate the academic and the theoretical, and I appreciate the historical context.
And remember, I'm only speaking for one district.
No, I'm just saying.
Colleagues might fall out their chair.
Yes.
Speaking for Monica.
Yes, speaking for Dr. Goldstein as a public professional responsible for the health of children and families.
There you go.
You're being led by the science, being led by what the public health is, and
correct.
Yeah, thank you, Chairman.
Yeah.
Thank you, Senator Washington. Other questions? Dr. Golson, I'm sorry, Senator Frey-Hester.
Thank you, Mr. Chair. I was just curious if the doctor could provide her thoughts on what happens when students have to quarantine. Like, what is the opportunity for education that they have, if they're required to quarantine for some reason? Thank you.
Yeah. So here we're lucky. We're a one-to-one district. So when our students have to quarantine, we can still have continuity of educational services. So for example, if it's one child, one or two, a very small number, probably we say typically 5 or less that have to quarantine, then the ability for them, what happens with them is that then they can get their instruction online by at least pulling up the information, getting the lessons online, turning that information back in, and the teacher can refer them to videos or other resources they can access electronically in order to at least get the lesson. We also are doing some virtual options. So depending on their grade level, they may be able to tap into someone else's classroom to get that virtual learning instruction. If the whole class, which we've had that case in the spring, has to shut down because they had 1 or 2 COVID cases and the entire class ends up shutting down, then, and the teacher's not ill, then that teacher can also deliver instruction from home virtually, just like we did back in the early stages of the COVID-19 pandemic, and everyone was virtual. So it really depends on the number of kids, but the one-to-one situation is what allows us to still do a lot of that communication back and forth and see the kids on screen with the live person, whereas those districts that are not one-to-one may have difficulty doing that.
One-to-one, you're referring to devices.
Correct. Devices, one device for every child.
Thank
Correct.
you.
Mm-hmm.
Other questions for Dr. Golson? Dr. Golson, let me ask you a quick question. In terms of elementary school, where they're likely not to have had shots if they're under 12, has there been any discussion of occasional random testing or pool testing? I know some jurisdictions are looking at pool testing where they'll do 3 or 5 or 7 children. If they all come up negative, you feel good. If you have one, you can look at the broader group. So anyway, has that been discussed or is that on the agenda?
Yeah, that's actually my 4 o'clock meeting to have that conversation. We first wanted to chip away at staff. The second is for our K to 6 students. We honestly thought, after talking to medical advisors early at the conclusion of the summer, we thought that there would be a vaccination available for those kids by the end of September. Clearly, it doesn't look like that now. And so that random sampling of testing is key. I spoke to the Chancellor of New York on Friday to talk through their nuances of what they're having to do around their random sampling. And I'm meeting with my team in 15 minutes to begin having that conversation. And knowing that there's this information out now that there might be some slowdown of access to testing, COVID testing, to see if there's any validity to that statement, just to make sure that when I open it up to do the random sampling of students, I have all of the tools necessary to do it. So we're starting that conversation now. So of course, I'll be communicating with you if we begin to move in that direction, but I'm hoping we will at some point soon.
Well, as Dr. Golson said, she has that meeting in 15 minutes. So we're going to let her go unless there's one more short pressing question. She might need a 5-minute break before her next meeting. I'm sure she's been on the go a lot. So Dr. Golson, thank you as always. Best of luck. And it's great for us to hear someone actually having to implement this on a day-to-day basis in a very large school system, 135,000 children. So thank you for joining us and thank you for your work.
And if you have any questions, please feel free to shoot me an email. I'll definitely answer. Thank you all for everything.
Great.
Bye-bye.
Jump back to Dr. Kotloff. Dr. Kotloff, are you with us?
She's on. Just trying
Okay.
to get it.
Dr. Kotloff, can we hear your voice?
Can you hear me?
Yes. Let me do a quick introduction. Dr. Kotloff,
Okay, great.
I think I mentioned some time ago, works at the University of Rhode Island School of Medicine, where she heads up Division of Infectious Diseases. She looks at vaccine development, and she is also board certified in pediatrics and pediatric infectious diseases. Thank you for joining us today, Dr. Kotloff. We'd like to hear about the impact on children and the need for mitigation efforts. We've talked about the mask going into effect very soon and the state board moving in a positive direction, and that'll be affirmed by the AUR committee in probably 15 days. We wish it would have been sooner. There's some of us who would like to see expedited, but nevertheless, we want to look at some of the broader questions that still face us. Dr. Kotloff, welcome.
Okay, well, thank you so much for having me here today. Just a little bit of background. I'm a pediatric infectious disease specialist, and I've also been running the vaccine trials at University of Maryland. So they're the trials in the Moderna adults, the Novavax adults, and now pediatric Moderna and Novavax are going on. And Jim Campbell is actually leading that under my grant. So I've had, a lot of kind of firsthand experience, and I've been pretty much entrenched in COVID since it took over my life in March 2020. I can give you a little bit of perspective on the pediatric problem. So right now, there has been close to 5 million cases that have been diagnosed among children in the US. And with the Delta variant, which is extremely contagious, the number of children who are infected is increasing very rapidly. So it went from about, I think it's like 26,000 a week or two ago to 200,000 in the last week. And even though children are much less likely to have severe disease, much less likely to have fatal disease, when you start increasing the numbers, then the number of children who have adverse outcomes increases, even though the percentage doesn't increase. So, for example, it's estimated that about 0.03% of children who become infected will die. And there have been a total of about 500 deaths so far. But as more and more children are exposed to the virus, their likelihood of having a bad outcome increases. So right now we are experiencing an increase in hospitalizations for children, and they can have one of two syndromes. You may have heard about that. They can have kind of the regular COVID, mostly lung disease, or they can get something that we call multi-system infectious disease in children. And what that is what seems like an overexcitement of a child's immune system. And so they can have inflammation throughout their body, especially it can affect their heart. And most will get better, but it is also associated with some fatalities, and children can get pretty sick. And so we are seeing increased numbers of cases, and we want to make sure that our medical system is capable of handling those increasing numbers. And what that means is that there needs to be access to beds, to staffing, to respiratory care, to pediatric focused transportation and ambulances, pharmacy resources, et cetera. And oddly enough, what's happening concomitantly is that there's been a rapid increase of general respiratory viruses that we see in children that tend to be wintertime viruses, like what we call RSV or respiratory syncytial virus, and to some extent, even the cold viruses and enteroviruses. The most important is RSV, and that's the most severe. And again, most children who get RSV infections do perfectly fine, and pretty much all children get RSV infections before they're 2. But we're actually seeing lots and lots of hospitalizations because of the sheer numbers that we're seeing among children, and that's a problem. Like COVID, it's the children who have some underlying risk factors who have the most severe outcomes. But that can be anything from, an underlying chronic disease or diabetes or obesity to congenital heart disease. So it can be, underlying diseases that affect kids that are otherwise healthy and going to school. So I think that's pretty much the state of things, and I'm happy to answer any questions.
Okay, committee, looking for questions. Pediatrics is a specialty, so feel free to ask any questions you may have. Senator Frey-Hester.
Thank you, Mr. Chair. I was just curious what the actual pediatric bed capacity in the state is, and do we have any idea of when those beds could be filled?
I can't answer, I'm sorry. I can't answer for the state capacity. We're actually having a call with the leadership of all the pediatric centers at 4:30 today to talk about capacity. So after that meeting, I will be informed, and I'm happy to pass on that information to you, but I don't know off the top of my head.
Senator Lamb. Senator Lamb. Okay, he might have been called away. He's
Yes, no, I'm here. Sorry.
Okay,
the
Clarence,
wrong mute button. So my question had to pertain to the rising number of cases. I think you cited the fact that there were about 26,000 cases and now increased about 200,000 cases in just the past few weeks. It would seem like this is mostly related to schools restarting, because that seems to be the main change here, as well as the increasing number of cases that we're seeing in the general environment. To Senator Hester's point, if we exceed the number of hospital beds, and pediatric hospital beds are far fewer in the state than there are regular inpatient beds, as well as pediatric ambulances and everything that's kind of pediatric focused, it's much easier to exceed capacity for pediatric patients. And the risk for these pediatric patients is very real when it comes to COVID too. You cite the fact that RSV almost everyone gets, and we know that from a provider standpoint. But we also have much more data and information about the long-term effects of RSV. For children that have COVID, how much do we know about the long-term effects of COVID, even for those children who overcome their condition?
So we've only been experiencing COVID for, I don't know, I guess it's about 20 months now. And so that's as long as we have any knowledge. And the cases in children were much fewer than adults for many reasons at the beginning of the outbreak. So the accumulated evidence of long-term problems is still, we're still learning about it. But what we know is that pretty much anything that can happen to an adult can happen to a child, and a child in addition can get other, unique syndromes. And so there is long COVID in children that we're trying to get a handle on. There are cognitive impairments and fatigue and chronic respiratory problems that kids can get. And long COVID doesn't necessarily affect only the people who are most severely infected. So that is one long-term consequence. And then for the MIS-C that we see, that unusual syndrome of inflammation that children get, there can be heart difficulties and clots in the arteries of the heart, or inflammation of the heart muscle. And while most of those resolve, some of them become chronic.
So thank you. So before I turn it back to Senator Pinsky, I just want to make clear to the committee then that what we don't know are all the long-term effects of COVID for children, right? And so, I think it's not without risk as we're sending children back and as they go back unvaccinated in some instances, that there could very well be long-term effects for these children that could be with them for decades to come, right? For some of them.
Yes, I think that's fair to say.
Okay, thank you. Back to you, Senator Pinsky.
Thank you. Before I call on Senator Ellis, I assume we know this, but your 26,000 going to 200,000 is a national figure. That's correct?
Yes, it is.
Do you have comparable numbers for Maryland or not?
I don't have the numbers from Maryland. I tried to get them before I got on this call, and I wasn't able to get them. But what I can tell you is that the numbers are increasing in Maryland. So it's a confluence of two things. One is that nationally, about 98% of the cases are Delta, the Delta variant, and that's extremely contagious. And it may have more of a tendency to affect younger people. And then, that probably is being exacerbated by the fact that children are going back to school. And so children who were having minimal contact are now having much more contact with other children who are likely to be infected.
Great. Senator Ellis, back to you.
Thank you, Mr. Chairman. Dr. Kotlov, thank you for being here. I'm having a series of conversations with folks in my school district, and with the virtual school we had in medium-sized, smaller Charles County, probably over 2,000 parents requested virtual school, and I think there were like 400 slots. And a lot of the parents who won the lottery for the virtual school, their children were like, no, I want to go back to school. I want to go back in person. So there's excitement among the kids, the students, to go back to school. And so with that in mind, and children going back to school all over the state already, Charles County started today, what kind of intervention can parents take to mitigate the spread of COVID, the Delta? I mean, the short-term effects are there, but long-term, they're also mentioned earlier, including a child under 10, I think it was last week, passed away in Virginia from COVID. So it's a real threat to our children. The children want to be back in school. And as mentioned earlier, I'm not sure if you were on the call then, but every single child at the school I went to this morning wore a mask, and they were not even taking it off. It was on. Some of them have very cute mask on, matching mask, match their book bag, And so there's excitement there of cooperation. But beyond that, what else can parents do in order to protect children, especially younger kids who can't be vaccinated at this time?
So I think that we do have solutions. And I think in my mind, this is a very centered on me opinion. Masks are not a big deal. And that is a very effective intervention. And in my experience, being a pediatrician for over 30 years, children kind of accept what is, the hand that they're dealt. And so if they have a disability, they learn how to live. That's who they are. That's all they know. and children with masks on play just as hard and learn just as well as children without masks, but they're protected from acquiring COVID and spreading it to others. And so I think that that is the lowest hanging fruit and the easiest intervention that can be done. And the masks are adorable. I think that most children can easily adapt. So that's the main thing. I think other interventions like social distancing and hand washing, and probably the second lowest hanging is to conduct as many activities as possible in the outdoors, because transmission is less there. And so if adaptations can be made for that reason, I think there are some very innovative strategies for testing that are going on that should also have an impact. But, from my point of view, masks are easy.
Right. And so
you
really
can have Halloween masks.
Yeah, real quick.
Yeah.
For me. You mentioned social distancing. I saw absolutely none of that this morning. Is that possible in any school, especially would you have 25, 30 children in a classroom? Is that even being thought of?
Right. Yes, it is being thought of, and spacing apart desks and things like that are being considered. But when I rated what the lowest hanging fruit was, I said masks were first and doing whatever you can outside is second, because that's most compatible with a child's behavior. I do think reminding children to wash their hands and social distancing are more challenging. You can do the best you can.
Okay, thank you.
Thank you, Senator Ellis. And finally, Senator Washington.
Thank you, Chairman. Thank you so much, Dr. Cutliff. I guess I'm going to ask about the not so easy and the part where we have to struggle. And I know perhaps you heard some of the discussion from Dr. Salmon and talking about the vaccine mandates and mandating for staff, and how we move towards vaccinating young people. I'm just wondering, where are you, or where are your thoughts on how we might progress upon that more difficult discussion?
Yeah, so I have spent a fair amount of time doing community engagement and talking about vaccines. I think the idea when people feel cornered and forced, then that's frightening for people. And so I have found it to be very effective to have as many situations where people can talk and just share the scientific information, that people can understand what the processes are to get emergency use authorization, and what the differences are between that and licensure, and just the processes for testing a vaccine to show that it's safe and effective in a child, and then getting authorization on that, and then the vaccine gets approved by the FDA, which does an incredible job. That's why it's taking so long, scrutinizing all aspects from manufacturing to delivery to follow-up. They have requirements for how long and how detailed that has to be. Then it goes to the Centers for Disease Control, and they assess risk-benefit and understand the data and make policy recommendations. If FDA makes a policy recommendation to vaccinate kids down to 12 or down to 6, then I believe the safety of that vaccine, I feel confident in the safety and effectiveness of that vaccine. And then communicating that to the public is the challenge. And we had to do it with adults when there were hospital mandates and other mandates. There was a lot of pushback. We've made a lot of strides. And I just think, allowing people to ventilate, express their fears, get information is the best way to move forward.
And just one other follow-up. So
Very-
barring a
very-
universal,
Senator,
this is, I think, key.
very briefly, Senator,
Well,
we're running out of time.
Barring a universal mandate for young people to be vaccinated, what group would you say, or groups, would be most, should we take that direction, would you, based on your experience, recommend?
So I would, what we're doing is we're marching our way down in age in terms of testing and approvals. And so I'm completely comfortable with 12 to 16 for the Pfizer vaccine, for the Moderna vaccine they've put in for an EUA. There's very good data on that. We don't have enough data on younger children, 6 to 11 years old, to make a decision, or whether there is a need or a value in going down to 6 months to 5 years old. We don't know that yet. And I think it would be premature for me to make a recommendation. I think we need to look, and we need to understand, and we need to understand if the vaccines work well, and how the pandemic is evolving and affecting that age group, and make a decision based on that.
Great. Thank you so much, Doctor.
Sure.
And finally, Senator Gallion with the last question. Dr. Sell has been waiting patiently, and we want to move on to her for the final speaker. Senator, question for Dr. Kotloff.
Thank you, Mr. Chair. Thank you, Dr. Kotloff. Just a quick follow-up on some of the data you mentioned early in your presentation. You mentioned that most children who get really sick or would die most of them have underlying risk factors. My question, I was looking at the CDC data. It looks like less than 500 children in the country have passed away from COVID. I was just wondering, out of those, how many had those underlying risk factors or comorbidities?
Those data are difficult to get your hands on. All I can tell you is that the majority have had underlying conditions, but there have also been perfectly healthy children down to infants, down to tiny infants, who have died from COVID. So it's a possibility when a child gets an infection, but it's rare.
So with it being mainly folks with, young folks with those pre-existing conditions or whatever, has there been any thought of just maybe trying to get the children that have those conditions to wear like N95s instead of making all children wear like these cloth masks? That there's, arguments over just how effective they are. We hear that, the N95s are great, but the other ones are, decent at best.
So I think that for one, from a public health point of view, that would be very difficult. We can certainly encourage people who have underlying conditions like we did in adults, and make vaccine available to them as a priority. But I think that's a difficult public health policy, and I think there's justification for making vaccine available universally. And two important parts of that are that you don't have to have an underlying condition to have a fatal COVID infection. And so how do you know which child that's going to be to protect that child's life? And so that's one part of it. And the other part of it is that if you have an unvaccinated population that's passing the virus back and forth, that's the situation that sets up the virus for mutating in ways that it can become more virulent, cause more severe disease and more contagious. And so it exacerbates the epidemic. It doesn't allow the epidemic to end. And that's what we all want to happen. And honestly, I know that the vaccines are frightening to a lot of people. They happen quickly. There is new technology for some of them that have been used. But I also think that this is a gift, a life-saving gift. We know that these vaccines have saved millions of lives. And it's very difficult to be able to stay on top of this infection without vaccinating our population.
Thank you.
And we also know a lot about the safety of the vaccine. I mean, you know, the last thing that anybody would want to do is release a vaccine that wasn't safe.
Thank you, Dr. Kotloff. We appreciate your contribution and the work you're doing every day to keep the state and the nation safe. Thank you very much. Now we're going to go to Dr. Sell, who gets the Patience Award for hanging in there and being flexible. Dr. Sell works at Johns Hopkins Center for Health Safety. She's actually a senior scholar there. Her work focuses on improving public health policy and practice in order to reduce health impacts. Today, we've asked her to talk about response policies, masking, and holistic mitigation efforts, which I think will address some of the questions people have already raised about what other things can we do to reduce the impact of COVID, in particular at Delta. Dr. Sell, welcome.
Yes, well, thanks so much for having me here to speak at this hearing. As Chairman Pinsky mentioned, I'm a senior scholar at the Johns Hopkins Center for Health Security, and so it's really great to see Senator Land here with his past work at the center as well. So my focus, as mentioned, is going to be on those layered public health interventions that can be put in place in schools to reduce risk from COVID-19. Based on some testimony I did on the Hill, I do think I need to mention that the opinions that I'm expressing here are my own and do not necessarily reflect the views of the Johns Hopkins University. I'll also say what I'm going to talk about today is founded on expertise gained through my research and over a decade of work on public health and pandemic preparedness. I'm providing this information based on the state of the science today, with the understanding that we're going to continue to learn more about the pandemic and the best way to reduce risks in the future. And also, as a parent of school-age children who were in Maryland public schools last year, I'm very well versed in the incredible cost of losing in-person schooling. I'm going to begin where Dr. Kotloff left off, although her answer to Senator Ellis's question is basically my testimony today. But that's with the understanding that COVID-19 is a severe disease that should be taken seriously, and that while most kids don't suffer those long-term effects, some do, and some even die. And it's worthwhile to prevent rampant transmission in schools. So at the School of Public Health, I've worked with a team of public health experts that are advising schools on policies and how to approach school safely. This is a complicated task, and often the devil is really in the details. So for example, how do we balance the advantage of lunch in classrooms to encourage spacing versus the increased risk of vermin from school food scraps? Or how many people can we put on the school elevator at one time? Or what do we do about busing? So often those compromises have to be made, and even more tricky, communicating those details to avoid confusion and also to achieve broad buy-in and compliance is really difficult, but it's also extremely necessary. Next slide, please. So my research group at the Center for Health Security has worked on how to think through public health interventions, how to balance the benefits and drawbacks, and when to use them and when not to use them. The first thing we suggest is to think about the specific goals of the intervention. And I'm providing a flow chart here for considering a broad range of school-related and non-school-related public health interventions as an example. So these colored boxes show the goals of delaying importation or geographic spread of the disease, interrupting chains of transmission, slowing community transmission, and reducing deaths. Many of these eventually overlap in second or third order effects, but they're separated here for simplicity. I say this because these goals are really important for us to choose what's right for the situation. In this case, the main goal is to control chains of transmission in schools so that they can stay open. We can safely assume that cases are going to be identified in kids. We're not going to have 0 cases, and that these cases themselves won't be surprising, but that the important component is to prevent those cases from becoming large clusters and super spreading events. And a secondary goal, as Chairman Pinsky said at the beginning, is to prevent these cases from causing a greater burden of disease in the community. So we should really be focusing here on what we can do in schools to prevent kids or teachers who are sick from getting a lot of other people in school sick. So, we also think about what level, one thing I want to mention here, just, after we think about the intervention, we have to think about what the levels of stringency are that are required for that intervention to work. So if a less intensive intervention can work, that's certainly preferred. So for example, we could range from mask use by high-risk individuals and their close contacts only, to mask use in limited high-risk settings, to universal mask use, depending on what's called for by the viral characteristics and the epidemiological situation. In Maryland, with the Delta variant and current transmission levels, I really do think that universal masking is needed. So next slide, please. So one measure, I want to mention also that no measure will provide perfect protection from the virus that causes COVID-19, but a constellation of imperfect solutions will go a long way to reduce those risks to kids and others in the community who might be affected by increased transmission. So these measures include masking, ventilation, air filtration, spacing, and testing, among others. Several of these are really self-explanatory, but I'm going to describe a bit more on masking and ventilation, which are two of my highest priorities. Vaccination is also an intervention. It's a pharmaceutical intervention, but it's also an important intervention that has already been covered. And although masking has some of those personal protective properties, its role as source control in relation to people who are sick is really critical. This means that the decision to wear a mask affects not only the wearer, but also the people around them. And evidence from both lab tests and real life observational studies shows that masks will significantly reduce transmission. A study I'd like to highlight looked at schools in North Carolina and showed that universal masking greatly reduced transmission in schools. The value of masks has also been reflected in studies in schools in other states, including Utah, Wisconsin, and California. Students and families where adults have chosen not to get vaccinated have more routes through which they can be infected and potentially pass infection on to others. And in situations where there's a significant transmission in the community, especially in situations where spacing is difficult, as we sometimes see in schools, this is a low-cost way to reduce risks overall. But importantly, I think, as we talked about just at the end of the last speaker's discussion, the masks really should fit properly and be worn properly. Another thing here, ventilation is another critical component that others at my center led by Gigi Gronval and Paulo Suski have studied extensively. Research has shown that both natural ventilation, that's outdoors and opening windows, and improved indoor air filtration systems can reduce disease transmission. So upgrading school air systems to increase outdoor air exchange or improve their filtration capacity, in addition to masking, is a good step in reducing transmission in schools. Similarly, HEPA air filtration units that can be placed in each classroom can help to reduce risks. And allowing students to conduct activities outside more often, including lunch breaks or when they need to take a break from their masks, can reduce opportunities for transmission as well. Just on to the last slide now, next slide. And so reducing risk from COVID-19 doesn't have to be an all or nothing approach. Although opponents can always point out one inconsistency or another, the combination of many risk reduction measures adds up. The approach to these measures must also acknowledge the changing epidemiological conditions and altering viral characteristics. We shouldn't just say one plan is one plan and we're going to stick with it forever. If things change, we should change our opinions with them. A more transmissible variant and more cases require more intervention when cases are low. And given the substantial transmission in Maryland as we reopen schools, we need to implement all CDC supported mitigation measures to the extent possible in order to allow students to return to in-person learning while decreasing the risk of transmission in school. So lastly, we know that we can't live in a zero risk world. We can't live a zero risk life. But given the costs of closing schools or quarantining kids, it really makes sense to establish systems that make it so that we can do things that we want and need to do while reducing risks in ways that are meaningful and manageable. Thanks.
Thank you, Dr. Sell. Questions for Dr. Sell? Senator Gallion, and then followed by Senator Salmonero.
Thank you, Mr. Chairman. Thank you, Doctor. You just kind of ended talking about, the zero risk world. And I too am glad that we're back to, in-person schooling. Just reading and the more we learn, looks like COVID in some form with different variants is going to be here for the foreseeable future. Matter of fact, I just read this morning there was a new variant detected in South Africa just in the last week or so. So I guess my question is, where's the off ramp with this thing? Where do we get to a point where we kind of say, okay, this is something that's going to be here, like like influenza, and we can start backing off of some of the things like the mask and such. When do we get to that point?
Well, I think that's a really great question. I think policymakers always need to think about that off ramp. I agree with you that we're going to have to deal with COVID-19 in a sort of long-term way, and that we need to think about sustainable ways that we can do that. I think that if we see that, case numbers go down, or we see that, when we have a lot of cases that they don't increase hospitalizations, I think that's when we sort of say, like, we want it to be to the point where it's more like the flu. It's not there right now, but it can be like that if we have more vaccination. And so I think, if we get to the point where it's something that, like the UK, they had a big spike, but they didn't have a huge number of hospitalizations or deaths, then I think that we can see, that off ramp there. But I think you make a great point. We need to think about how we're going to do sustainable things. We can't just do unsustainable things for forever.
Thank you for that. And just one quick comment, Mr. Chair. We heard in previous segments how beautiful these masks are that we see on the children. There's one thing a lot more beautiful than that, and that's the smiling faces of the children themselves. So I just want to point that out.
Duly noted, and I think we all agree with that. Absolutely. Let's go to Senator Simon Ayer, followed by Senator Ellis, Fry, Hester, and Lamb. Senator Simon Ayer.
Thank you, Mr. Chairman, and I can agree with Senator Gallion. I've seen his 4 beautiful daughters, and they smile very, very pretty. And thank you for your presentation today. One thing is, we aren't one Maryland in the sense that different areas have different transmission rates. And Senator Gallion kind of went to where I was going to go as far as as far as the off ramp. Do you have any recommendations? Because I don't think we have any at this point. When you stop wearing the mask, when how many cases there are. Do you have any idea of is there a standard for that?
I don't think that there's an overall sort of final standard on what the case numbers need to be. If we had continued, at a level that we had sort of seen earlier, I would have said that's a more difficult question for what we need to do right now, because, right now it's very clear we need to have masks. But if we're seeing those low, like 1 case per 100K or something like that, like we were before, I think that's just a background rate that we're going to have to, say is going to be happening. Now, we, again, want to see that if we see cases and if we start to see a rise, that we can handle it in our hospitals, and also that we have the flexibility to go back to these protective measures if they're needed. I think that, that's something to take into our hearts, that changing policies based on the changing epidemiology is something that we should accept, both in the sort of taking back restrictions and also adding restrictions if it's necessary. So I think that, I don't have a real solid number for you, and I'm very sorry that I don't, but I think that it's sort of just, we need to be flexible and respond to what's happening around us.
So let me just ask, nobody wants to see any child sick or their parents getting sick because of that. And we need to put in protections, and I understand. But if you have a jurisdiction where it is 1 per 100,000, and you have some jurisdiction and it's 100 per 100,000, they're very much different. Do you think it's a wise policy to have a one size fits all for Maryland? So where some are at the rates that you were saying, you could take the mask mandate away, but other jurisdictions which are 100 miles away or more are having these high transmission rates. Do you think it's best to have one policy across the state, or have local jurisdictions looking at their particular jurisdiction and making those decisions based on science?
Well, this is a difficult question, because a lot of times, you would hope that everyone makes the decisions based on science, and sometimes, there's other sort of decision-making factors. And so, I think that at some point, having a little bit more flexibility is good, but if it's an overall sort of situation where we're not seeing the appropriate measures being put in place, then a larger, broader brush can be applied.
Thank you very much.
Thank you. Let's go to Senator Ellis.
Yeah, thank you, Mr. Chairman. Thank you, Dr. Sal. I'm going to modify my question a little bit based on the previous questions. So we know that COVID-19, the Delta variant, is really spreading all over the nation. In Florida, last week, the report in a school district in the Tampa area had over 2,000 students on quarantine. We know that it's spread in a lot of schools, and Tampa area has been kind of one of the worst, but North Carolina, other areas where schools are in, it's just really spreading in the schools. And so we have in Maryland, my question is, should we wait till the outbreak is at a certain level in a district to take action, or even if it's low in a district, should we have preventive measures in place? And I know we talked about masking, that's the number one that we have implemented. Your slide talked about spacing and some other issues, ventilation. Spacing, it seems like if we keep going with the standard school model of all our students in particular schools showing up at the same time, it's impossible to really space. So should there be other things that maybe the state board be looking at to keep our schools safe, and not wait until things get really bad to say, hey, we will do these draconian measures?
Yeah, so I think that it depends on the cost of the intervention. So masks seem like something that it's fairly low cost. My kids don't have a problem with them. The only time they actually had a problem with them was one time after I ran and I complained about wearing my mask. And then we had about a week of complaining about masks. And then it stopped after I stopped mentioning it. So I think masks are a pretty low cost intervention. But I would say, like, if you saw something coming, you wouldn't do something, with a lot of cost, like closing schools in anticipation, right? So I think it depends on the cost of the measure. But I do think that some things that can be done are, and I know that many schools already moving in this direction, but improvements in ventilation, HVAC systems, portable HEPA air filters, those types of things seem sort of in the middle ground, which seem, something that you guys could move towards if you had the opportunity.
Yeah, we'll follow-up question. Are there state requirements or mandates of ventilation, or is it up to each school system or each school building to really take care of that? Is that a voluntary effort, or is it being monitored by your knowledge?
I'm not monitoring that, and I don't know the specifics of that. I guess I shouldn't even try to speculate.
Okay, thank you.
Thank you. Before I go to Senator Hester, I just checked a recent map, Doctor, and it looks like every county in the state has a high ranking of transmission, 100 plus cases per 100,000, and only 3 counties have substantial, which is 50 to 100 per 100,000. So at the moment, we don't have any that have 1 or 2 or 5 or 6. So when we get to those numbers that are much closer to us, then the idea of having different policies for different counties would make greater sense. But right now, almost the whole state is in a pretty serious way. Is that correct?
I mean, I feel like that's what I said. I hope that's what I said. That, when everything is substantial, then I think that there's it makes sense that the policy is fairly uniform. When things come down, then I think that people can, make some more of those nuanced decisions at lower levels.
Great, thank you. Senator Hester.
Thank you, Mr. Chairman. I was just curious, as we talk about quarantine and isolation and potential school closures, Dr. Sell, do you have any specific metrics that you look for that should prompt schools and school districts to take those steps?
Yeah, so, for people who we know are sick or have those specific close contact situations, then, quarantining them, isolating them, is a good thing to do to prevent the transmission of disease. But, with that, quarantine and isolation, we're getting a lot of people being taken out of school. We have lot of options, a lot of people who are losing school. And so it's sort of thinking through, if we're going to close schools, that's really a last resort in my mind. I think if those educational services can continue without degradation, I would say keep the schools open. Even then I would, if you're trying to close smaller groups down, I would say cohort or classes rather than, school by school. So, as for specific metrics though, I think educators probably have a better idea, of what real degradation of those educational services means and what levels of sort of school absences mean that, it's just better to sort of go to all virtual. But I would do that as a very last resort.
Thank you. We are at 4:30. We have two more questions from Senator Lamb, followed by Senator Washington. I'm going to beg your indulgence to stay a few more minutes longer, and we'll complete this. So with that, Senator Lamb, you're back up.
Thank you, Senator Pinsky. Dr. Sell, so that there are really only a few public health tools that we utilize, the same tools that we've been utilizing since the beginning of the pandemic, right? So it's masking, which is probably the lowest hanging fruit, distancing, which is difficult in our schools, vaccines, which we talked about with Dr. Salmon earlier, testing and contact tracing, of which LA County school system has now moved to fully testing everyone, including students, weekly, air filtration, circulation, and de-densification, which is ultimately closure of our schools. Now, those tools that we've utilized throughout the beginning of the pandemic pretty effectively, masking is still probably the lowest hanging fruit that we can reach for that requires low intervention, low risk. Is that right?
Yeah, 100% agree. I think that that's definitely the easiest thing to do.
And it's not a one size fits. It is, I guess, to the concern that it's a one size fits all for the whole state. The whole state, as Senator Pinsky mentioned, either under high or substantial risk, and based on CDC's recommendations from their scientists, we should all be masked indoors. Now, I just saw an article that said that the governor will not be waiving the mandate for the regulations for the state board's requirement for masking at our schools to take effect earlier. Unfortunately, this means that one of the legislature's committees will have to put this into regulations, but there'll be a 10-day delay in this. Personally, from my point of view, I'd rather see our students' beautiful smiling faces because of a mask rather than them living with long COVID or be dead because as a state, we refuse to follow the science. And so I hope that we as a state will move forward quickly with this masking mandate, because we know that these public health tools that you stated so well in your presentation do work. And that's really the lowest hanging fruit for us to be able to at least safeguard our students as they go back.
Yeah, I support that as well.
Thank you. Back to you, Senator Pinsky.
Thank you. And finally, Senator Washington.
Thank you, Chairman, and thank you, Dr. Sell. Some of this reminds me, every summer, my brothers and sisters, my parents would drive us to North Carolina to visit my grandma. And as soon as we got out of the car, we say, "Are we there yet? Are we there yet?" And so what happened is that my parents would sort of explain to us at different markers exactly how long the journey is. I know you don't have a crystal ball, but so that we can kind of get out of this space where we saw back in 2020, we thought 2 weeks, 6 weeks, and we continue to sort of replay this. What are we looking forward in the fall and up next? What are you seeing the course of this disease and of what we're dealing with?
Yeah, so hardest question for last. I feel like I've given up prognosticating because, this pandemic has set us so many curveballs. But, I think, we're going to have to deal with Delta and its increases over the fall and winter. But I think that we're going to be able to get a vaccine for kids before the end of the year. And I think that that's going to change things quite a bit. We may not get a ton of, we might not get full coverage, right? Because it's very hard to get full coverage. But I think it allows us to sort of think about this differently when everyone who's had a chance can protect their kids and their loved ones. There are still a few notable exceptions. But I think that sort of we need to think about then what are our goals and have we made this so that it's a disease? Have we vaccinated to the level where we're not having these incredible spikes in hospitalizations and deaths? And if we can get to that point, then I see us sort of the light is at the end of the tunnel. And so I think that, I'm waiting for those vaccinations to become available. I'm certainly going to be vaccinating my kids as soon as they are able to.
And just to be clear, Chairman, just so that we're talking about the next academic year, so that we can that having a mask mandate exercising throughout the academic school year is the low-hanging fruit, and debating mask on, mask off, really that's something that from a public health perspective, ensuring that as many people as possible are masked is something we should just concede and then move on from. Would that be fair?
I think so.
Okay, thank you. Thank you very much, Chair.
Thank you. First of all, thank you, Dr. Sell, for your patience and your information. Very informative. And I want to again thank Dr. Golson, Dr. Salmon, and Dr. Kotloff. All of them did this on short notice, and all of you committee members rallied. I have to say thank you very much. We weren't sure what kind of response we were going to get, but I, for one, found this very informative. We don't have any magic solutions. I think it affirms some things we believed, and it raises some fundamental questions. And we may have to have a subsequent meeting to talk about implication for policy. I think we all have to sort of like take this in and figure out what comes next. And I think the questions of where's the endpoint, what is the off ramp, how do we measure that, what will it be 4, 6, or 12 months from now, particularly if there are more vaccination for young people, and what the policy should be. So again, want to thank everyone. I want to particularly thank Russ Seidman for helping pull this together, as well as the EHE staff. Mr. Seidman did a great job, and I want to thank our committee as well. So thank you. This concludes the hearing. Thank you.